We're getting a live presentation from Centro, California. Hi.
Hello.
Dr. Ansari, how are you?
Hi. How are you guys? I hope you're having fun. Sorry, I'm missing the occasion, but I am very happy to do this live so that you are part of my own presentation here from this small town, which is about 120 miles from San Diego, 40,000 people, and we set up this OBL about 7, 8 years ago, and I'm pleased to share with you with our experience, especially with the new novel technology with laser atherectomy with the DABRA. So I'll start with my introduction brief from my staff. I have on my right side Melissa, who is going to assist me with the procedure, and then we have on the back side is Alex, and on the left of Alex is Jesus, who will be manning the machines, and then Monica is she has kindly come over from Santa Monica to help us with the nursing, and then we have Greg, and then we have Michael. So this is our team, and I will start first immediately telling you about the case. So can we have the first slide, please? So this is an 81-year-old male who has had this gangrene of the right great toe for almost 3 months. And we are in the remote area, and people are not always referred in a timely fashion. So you can see this guy has been going to the wound care center and has a non-healing ulcer, which is now necrotic. And he has a history of all the risk factors, as you can imagine: hypertension, diabetes. He's a former smoker. So can you show me the next slide? So we already did his angiogram and showed that he has a subtotal occlusion of the right SFA, critical stenosis. And down below, can you show the next slide? There's a wire on the side. His anterior tibial artery is completely occluded, and his posterior tibial artery is multisegmental stenosis. Peroneal is critical stenosis. Next slide, please. And he has a single vessel runoff via the posterior tibial artery. So you all have been talking about DABRA and laser atherectomy and say why you are so excited about this. This is not a very hard case to fix. I think there can be several approaches to this. You can even do simple balloon angioplasty, or you can go with any atherectomy devices. So what I choose to do DABRA is simple. Number one, what I want to make a point is that DABRA is just a wire. It's a 1.5 French wire, and I can easily get into this wire into the lesion. Rather than crossing with the lesion, I can do with a wire. And at the same time, it's 1.5 French. It gives me enough lumen. And the second attribute is I can easily go in there and ablate the vessel, the plaque. And the third thing is no distal embolization. I think that's the point I would like the audience to take over. We have done close to about 250, 260 cases. We have not had a single distal embolization. So this whole concept of putting a distal protection device is a moot point in our practice, which is very important when you're putting in a remote center. You don't want any complications. And if you want to do things simple, safe, and get out of this. So I'm great advocate of this simply because I want to get out without, and these, I don't have any backup or surgical or something. 120 miles is my nearest San Diego. And as I said, you know, you can do complex cases here in a remote city. So this is what I have the plan. So I've already planned it, that I'm going to start doing this procedure with the wireless device, which is already in position. So we have got the new bright tip.
Dr. Ansari, just to introduce you the panel here, we have Dr. Graziani, Dr. Sada from Japan, we have Dr. Sawaji, and me, it's Dr. Balar. Now, before you start, I would want to ask the panel, Dr. Sata and Dr. Graziani, as well as Sawaji, what would you do in this case? Would you do what is being planned, and would you plan to treat distal lesions also up front?
Is
Dr. Graziani, what do you think?
Okay, or you do?
I think the case looks quite easy in terms of revascularization. There are basically two lesions. There is a tight stenosis in the proximal SFA, and a segment of the anterior tibial artery suboccluded. So basically, I think stenting the SFA or atherectomy and ballooning the tibial artery will be the best strategy, in my opinion, but I don't want to interfere with your...
How about you? Any other thoughts? Or you can, Saraji?
I agree. I think the inflow is important, opening up the SFA, and then if you can, get through the AT with the Dabra catheter or any of your choice, microcatheter, and improve the inflow.
Okay, so let's see what you would want to do. Thanks.
Okay, sorry. So I heard, sorry, I could not hear you very clearly, but I heard that the panel agreed that it's reasonable to go after that SFA and either put a stent or atherectomy or whatever you want to do with the plan, and then perhaps go down. So
That's correct.
that's good. So that's exactly what we thought about it. And remember, this history is about 3 months. 3 months of this ulcer and gangrene. So he has been deprived of any blood downstream. So yeah, what we would do is we will do the SFA, we'll watch the patient, and if we need to, we can go down and fix that anterior tibial artery. There is no reconstitution, but we have done that. We do it routinely in our practice. But for the course of the argument and for the sake of the course, I would like to demonstrate how it works, like as exactly what the panel has suggested, and perform atherectomy of the SFA with this unique device. So here, if you can see, can you focus on the? I'm almost ready for you, ready with the plan, and you can see there's a bright tip, and you can see it's right positioned, right proximal to that lesion. So I'm going to start, and it's a very simple device. It's already in place, and I'm going to go and start firing here. Oh, can you please push this? It's not on. Jesus, put the treatment button on. Treatment. Okay, ready. Thank you. Okay. Ready. Okay. Here we go. I start firing. So I'm going to go very slow, and there is a subtotal lesion, and I've crossed it nicely. So the thing is, sometimes with a wire you get stuck up there, you try to get subintimal, especially if it's a total occlusion. We don't have such problems, so I'm just using the wire and making a few cuts there. About 1 centimeter a second, I go a little slower, and there's a second pass, and then I'm going to go slightly slower, and then sit here for a little while. Third pass. So I've done about 4 passes now. Okay, so I'm done here, so let's give me the wire, please. Take a little picture here. So you can see a little bit bigger lumen here. Let me take a picture. Okay. So you can see a little bit bigger lumen. There's a little haze down on the side. Let's give me the wire. And what I've done is really made a bigger channel. But the most important thing is, more than the channel, is we have made what I call the plaque softer. And so when I subsequently dilate with the balloon, it will be a lot easier, and it will be very low pressure. So it's going on a side. Here we go. So you can see easily I made a loop, and my wire just slipped past by. When I did a diagnostic, I tried to put a wire. I was getting looped in. I didn't try very hard, but it was just looped in. And now I've got a bigger channel, and I will easily able to cross it. So my guess is this is about a 6 millimeter. So give me a 6 or by 20, please. So a short balloon will go over and then post dilate it at low atmosphere. So I will come over there with a short balloon and right at this point. We could have used a little bit bigger balloon, but that's okay. All right, just go up, please. Okay, give another 500,000 more. Yeah, thank you. Just go just slowly. So we just try to go up slowly. I believe in the vessel prep, so no point in 1, 1.5. One and a half. Two. Okay, so we just give a gentle inflation, and I think it's important here in these cases to be patient. We do inflation 3 minutes routinely. The last case I did was up to 8 minutes. So I think patience is the virtue. You don't have to rush up. You don't want to cause any dissection. And the way this device works is because we have what we call the pulp the lesion. We have made into small normal chemistry like normal hydrogen, oxygen, all the basic molecules. So when you finally go and ballooning it, you have a very low pressure and you're able to make it a much nicer lumen. And then, as I mentioned earlier, was that your chances of distal embolization, which I think is the key. It's almost it's a single vessel runoff. You saw it by posterior tibial artery. So if you can avoid that, I think that's a big plus, and your floor time is less, and you can get done quickly, and then you can move on to the other cases. So, any comments from the panel?
We're good. Would like to see what your completion and see if there is any dissection. But
okay, yeah, I think that's
low pressure balloon looks like you got good results.
Yeah, so I think that's the important point. Dissection. If you use a flow limiting dissection, you end up putting a stent. Our use of stent is very, very. I mean, we do use. I shouldn't say that we don't use it, but I would say about 5% or less. We like to use stents as a bailout. And if I can get away with this, so the thing I'm trying to not of anything is that by using this technique and using minimal technique, what I call it, you are able to save cost, floor time, and hopefully get a reasonable results. We were the early participants of the study, which led to FDA approval. And all I can say is, although it's a very short study, but we had 60 cases and up to 180 days, we had no significant events. So after having done quite a few hundred cases now, we feel confident that this technology is ready to take off, and it should be part of every cath lab without risk of any major events. And we can do all these cases very, very safely. Okay, how many seconds now?
3 minutes.
It's up to 3 minutes. Shall I give another minute? I usually do 3 minutes, sometimes 4 minutes. It's common. So how many atmosphere?
2.
Huh?
2.
So we are only 2 atmosphere. So I kind of, it looks pretty good now. Okay, so 3.5. Let's do it 3.5 minutes. Okay. Okay, down, huh? 330. Okay, down.
Down from 2.
So only 2 atmosphere. You can see. Didn't go very high. I'm going to take the balloon out and see how we do. Okay, take it off. Yeah, just so we can get a better picture. But over the wire, not all the out of the. Yep, come out. Stop, please. Thank you. So I'm going to flush my sheath. We keep a therapeutic ACT around 230, 240. Okay, here we go. Can you take off the roadmap? Okay, ready. Let's take a picture here. Here you go. Bingo. So you can see there is no dissection. And just to prove the pundits, there's a little bit of wire which is causing it. I'm going to take my wire out just to make sure that you all agree that there's no dissection, because the wire sometimes causes a little artifact and can see there might be. So just to make sure we are absolutely on the same page, I've taken my wire away. So there is no wire artifact causing. And have you, what's the blood pressure, please?
It's 135 over
Okay, you can get some nitro ready, but 500. So let me just take a picture. And you can see, you can't even tell where the lesion is. It's perfectly fine. I don't see any dissection. You will all agree. There is a secondary lesion down below. If you want, I can just simple balloon it, but I don't have to. It's about 50% from my eyes. Maybe you guys feel differently. So as a point, in proof point, I will go distally because there was a single vessel runoff and I did not use any distal protection. And I want to prove it my point by showing you the distal flow. So can you go all the way down to the foot, please?
Well, that's a great demonstration of the technology. I don't think you had any dissection, and completion angiogram would definitely tell us if there was any embolization.
So this is what I'm going to show you, the last picture. And you can see beautiful posterior tibial artery, no problem there. You can actually see a little bit of blush in the metatarsals. This is why collaterals. The anterior tibial artery was occluded, as we know, but you can see a little bit more flow towards the foot. So I think that's what I wanted to prove. I wanted to prove that there is no distal embolization. You have a low pressure balloon, only for about 3.5 minutes. I think that's the key. People try to go rapidly and try to go very fast into nominal pressure. I think that's wrong. You should not do that. You should build up to your atmosphere very, very in a graduated fashion and go up to about 1 or 2 or 3 atmosphere. Oversize the balloon slightly, and you will see that all the residual thing is bulk, and you do not need any distal protection device. You do not need any stents. And in the fluoro time of 2 minutes and 30 seconds, I'm done with the case. Now, if you want me to prove, I can do another thing. I can show you an IVUS, show you inside, and we've done a lot. It's up to the audience, their interest is, but I can tell you, after having done tons of IVUSs, we have not seen any distal, any dissection distally at the point. I think as far as the case is concerned, I'm done. I'm very happy, and I leave it to the panel to have some discussion, and I can answer you more questions.
First of all, congratulations. It was a good result, and we all agree you didn't have any dissection. The panel may have more questions. If there is any, please feel free.
Just a question. What about the tibial lesions that we saw before? Do you think will be important, crucial to treat it, or you think you got the best result possible?
Yeah, I think that's a good point. There's a distal lesion. I can go and balloon it. I think that's a very simple lesion. I would not do a DABRA on that case. Remember, DABRA is 1.5 French in diameter, so it's about 1.7 millimeters. The distal, if you look at the lumen size, can you show me the picture, please, on the SFA? If you see our picture, the minimal lumen diameter, although there is a lesion, this is a 6 millimeter vessel, but the minimal lumen diameter is at least angiographically, show me the Jesus. So angiographically, it's about 3, some give and take. So yes, it can be done very easily, but I'm going to get the patient back. I don't like to unnecessarily and make it in peripheral vascular disease, come over and do cases. But if the audience wants, I have to just do a simple balloon and I'm done with this. My own thing is I will leave it alone because I don't think it's flow limiting, and I will see the patient, I will follow this patient. So if I don't see any signs of healing, I will bring him back in about 2-3 weeks. The nice thing about practicing in this valley is because we are confined, I never lose these patients. They are very loyal, they come over and they are very diligent. So we can say, and we have a protocol that we follow these patients in 24 hours. So if we see any signs of not healing and everything, I'll come back, and maybe it actually, that lesion may not be that enough, but the one below that, I will go after that anterior tibial artery, which is a CTO, and then we'll try to get more flow directly to the toes if it does not heal. But as far as I'm concerned, I'm quite happy with this. I wanted to teach you about the Dabra and how it does it. I don't think it will need just a simple balloon. So I think I will leave it alone unless the panel suggests otherwise.
Well, I think we all agree we'll leave it for, and hopefully if the ulcer does not heal and if you're going to be following, ET would be my choice of going after
Yes.
on the second shot if the ulcer does not heal.
Yeah, I think I agree with
Great
that.
job.
Okay, well, thank you very much.
Thank you.
Okay.